Welcome to the Athlete's First Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
All right, welcome to episode 5 of the Athlete's First Performance Podcast. Today we're going to be talking about the overhead athlete shoulder, and we have our first special guest, Wesley Talley. We'll start with a little bit of a background on what Wesley does and why his expertise is needed for these overhead athletes. And then we'll get into a little bit of treatment, evaluation and treatment. So how's it going, everybody?
Pretty good. Excited to hear Wesley's thoughts. Haven't seen him for a while. We were just talking earlier. I haven't seen Wesley since CSM in Denver, so it's been a while.
Oh yeah, that's the last time I saw you too, I think, Wesley.
Yeah, it's been about a year, little over a year since I've seen y'all, but appreciate y'all having me on here. Enjoyed listening to everything else. A little background. So pretty much born and raised in South Carolina. Went to grad school or PT school at MUSC. So that's where I met James and Josh. From there, stayed in South Carolina, moved to the upstate, worked a year, and then decided to go ahead and do the sports residency program that similar to what James has done, but just through ATI. And then from there, when I finished, I stayed on with ATI working in Spartanburg and kind of started a little niche within the Spartanburg community as treating a lot of overhead athletes, particularly baseball players, volleyball players, swimmers, different things like that.
Why did you decide to specialize in sports physical therapy?
I think it's the same for a lot of people. I grew up playing sports. Within my first year, being out of school, I realized quickly there was a lot of things I didn't know. And I know y'all talked about it too, how you didn't feel comfortable actually treating people. So for me, it was what better way to, one, be a better clinician and learning how to treat people than by just learning more through a sports realm. So something I was passionate about, but also gave me the opportunity just to be able to treat people.
So I know James has a background in football, and I know you kind of have I guess both y'all have a multi-sport background. I know you played basketball. Were you a baseball player too?
Yeah, I played baseball in high school. It wasn't necessarily my number one passion, but I did play.
Okay, sweet. And yeah, just to give everyone a lay of the land here, I'm not the biggest expert in overhead athletes. So I'm going to rely on James and Wesley. So I'm just going to be moderating, I guess you could say. But do you want to go ahead and get started? And I guess I know your residency, they have a big focus on the overhead athlete. You said you work with baseball players most. Do you want to just talk about what you most commonly see with those athletes?
Yeah, from a baseball perspective or an athlete's perspective, from a lot of what I see is, we can label it as bicep tendonitis, some type of labral slap tear. Doctors call it little league shoulder, depending on the age. Got some posterior impingement, anterior impingement. And even now, every now and then I'll see I'll label it as thoracic outlet, but something like neuro based care going on there.
All right. And then, and James, you can answer this question too, or add in if there was anything else that you would say. As far as surgical issues, what are you seeing with that?
For me, surgical wise, a lot of labral repairs or different type of stabilization surgeries. I do see some slap repairs, but don't see a ton of baseball players with shoulder surgery. If I see a baseball player who's surgical, it's more like Tommy John or something elbow related. But every now and then I'll get like a posterior labral repair or anterior stabilization type surgery. But a lot of times it's more on the elbow for baseball players.
Yeah, and in Colombia, we would see mostly posterior labral repairs with some rotator cuff repairs in some of these high school kids. So, which was pretty interesting. Usually don't think of younger kids having rotator cuff repairs, but it was there. And those are a little bit more challenging than just the posterior labral repairs, but it's good. Good to get that experience seeing a variety of different surgeries in post-op patients.
Yeah, I would say from a post-op realm, it's a little different when you get to the overhead athletes. It's not like they just need to get back to their day-to-day life. Like they got to get to a higher level. So it can be a little bit trickier. And you throw that rotator cuff in there and it definitely can cause a little bit of problems.
When you have somebody come in that's post-op, and we'll just go a labral repair or something like that, not a Tommy John's, what are you telling them? Because obviously if you have somebody come in the knee and they have an ACL reconstruction, you're thinking, 9+ months. Are you expecting a similar timeline for those throwers, or quicker or slower?
Timeline wise for full return to play, yeah, you're looking at 6, 7, 8 months. But that's like full go if they're trying to get back into pitching with no restrictions or anything. For getting them back to throwing and even playing a little bit, if they just want to play in the field, it's a little bit quicker of a timeline. Normally it's roughly 4-ish months before they're looking to throw, and then you just kind of progress them from there. So I would say 5 months if they're like a position player, even into 6 months. And then if they're pitcher full go, yeah, you're looking at 8-ish months from there. I don't know if you're any different than that, James.
Yeah, it's pretty similar. And with those pitchers, they have to go through even longer interval throwing programs. So 8 months would probably be quick as long as everyone is on the same page and there's no hiccups in the way. So we'll get into our return to play stuff in a little bit. But yeah, I agree with everything that you were saying so far, Wesley.
All right, so let's go ahead and move on to the evaluation. I guess we can just start with if a baseball player comes into the clinic with some shoulder pain, what are you asking them as far as the history goes? What type of questions?
So some of the questions or the things that y'all talked about last episode are similar to what I'm asking. So, just trying to get like a good general history, just what aggravating, easing factors, things like that. But in a baseball realm, some of it depends on age. So one thing I'm always asking is the growth spurt. Have we grown here recently? If we're dealing with, elementary school, middle school, yeah, they're probably in the middle of a growth spurt. So that's going to be number one. Playing history, how often do you play baseball? Is that the only sport you play? Do you play other sports? I've even seen it. You got to ask, how many teams do you play on? Sometimes these kids are playing on 2 or 3 travel ball teams, and they have practice every day and weekend games every weekend. You always want to get what position they play. So, they're going to say, I'm a pitcher. Well, then you need to figure out, well, do you play another position? Are you the catcher? When you're not pitching, do you play in the outfield? Just because that's going to give you an idea of how much are they actually throwing. Two, here in South Carolina, everyone pretty much plays baseball year round. Where y'all are might be a little different because it's a little bit colder, but you got to just kind of dive into like, when was the last time you took a break from baseball? And by a break in baseball, I mean, like, when's the last time you actually didn't touch a baseball? You talk to these kids here and they're like, yeah, I haven't played in a game in 2 months. And then you start asking more questions. They've been practicing every single day. They've been throwing bullpens twice a week, 3 times a week, different things like that. And then you always got to follow it up with also weightlifting. So winter times, they're trying to, get bigger, get ready for the season. And everyone's favorite lifts to do is bench press and lat pull downs. They're all just trying to get bigger. And so you just got to dive into how much are they actually working out, what kind of weightlifting they're doing, and go from there. And then the last thing I dive into, and it's not something that I do with every single person, I'll do this more with like high school kids and even into the college professional realm, is like, hey, where in the phase of throwing does it hurt? When you're getting to the younger kids, a lot of times they don't know. They don't know when their arm hurts and what position they're in. But as you start to understand your body, these kids, the older ones, do a lot better. And like, yeah, when I'm in the late cocking phase or I'm in the follow through phase, that's when I feel my pain. So from there, it just kind of drives you into like, oh, it's probably most likely this before you even get into any objective screening. Just from asking like, hey, where in the phase of throwing does it hurt?
Yeah, and you
Anything else, James?
You definitely hit on a lot of key points. I'm just going to bring out a little bit of a research article, current concepts in arm care exercise programs and injury risk reduction in adolescent baseball players. And you hit the nail on the head. So volume is a huge injury risk factor. So high pitch counts. this is a pretty crazy stat. Pitching more than 8 months out of the year led to a 500% increase in injury. Playing on multiple teams and showcases, super popular in the South. Going through and continuing to pitch with arm pain or fatigue, and throwing more than 100 innings per season. So, Wesley, when you're talking to these kids, do they know how many innings they've thrown per season, or like what their average pitch count is when they go out? Because I don't think any of the kids that I worked with actually kept track of that.
No, a lot of times, no, they couldn't give you an exact number. Sometimes that's when you rely on the parents who are usually with them and trying to see if they can get it. But it's just kind of asking questions of like, hey, are you the number one starter? Well, then you're kind of thinking, okay, they're probably going to be pitching more than normal. You're just trying to tease in like, okay, how many pitches does it take to get you warm up? So sometimes these kids are out here before the game starts, they're already throwing 90 pitches just to warm up. So it's just trying to kind of just tease out, asking the specific questions of how many pitches do you throw in between innings? You know, are you averaging about 80 plus pitches a game? And they can kind of give you that general. They can be like, yeah, I probably was over 80 pitches each game where I got to 100. But a specific number, 9 times out of 10, they're going to have zero idea.
Yeah. And one more thing that you said is, what other positions do they play, or what other sports they play? I was working with a really good athlete in South Carolina. He was their number one catcher. He was going to be their starting quarterback, and he was also a pitcher. And he ended up having elbow surgery, Tommy John surgery. So it's super important to ask what other sports they're playing, because playing quarterback obviously puts a lot of stress on their shoulder and elbow.
Yeah, I really like that question that you asked. When's the last time you touched a baseball? Just to make it very clear that you're trying to get an idea of when's the last time. I mean, because that's pretty straightforward. If you just say when's the last time, you've played in a game, like you said, they could have been practicing the whole time. And just like the article that James talking about, we know with most injuries, particularly overuse injuries, it's a volume issue. So get an idea. A straightforward idea of what that athlete, what their volume looks like is super important. So when you go into you ask them if they can identify what phase of the throwing motion do they get their pain, and that leads you into your objective measures. So what type of things are you looking at? I'd kind of like to know how, you don't have to go into the general shoulder evaluation, but just what type of things baseball related are you looking at in the objective exam? And then are you adding any sort of the basic objective measures, such as like range of motion, strength testing? What are you looking at with that?
Yeah. So day one, I'll, the general stuff, I'll do active range of motion. I'll check their strength, elbow by the side. So ER, IR, I'll check their scaption strength, seated like y'all do. But from a baseball specific, I'll get them actually supine, and I'll do passive range of motion. So I'll work into flexion. I'll do the 90-90 ER, 90-90 IR, and then check a cross body range of motion. But with each of those, I'm trying to get pure glenohumeral motion. So I'm trying to block scapula as best I can, whether it's with my hand, kind of just pinning it down, different things, just to try to get a true glenohumeral motion. Because if you just let them go straight flexion without blocking or scapula, then you're probably going to get some like lumbar extension, some compensation just for them to get to that. From there, I'll flip them over and I'll check 90-90 ER, IR strength to get a sense of what both those are. And then the last thing for usually day one is I'll get a grip strength. In the last episode y'all talked about elbow by side, elbow straight out in front of you. And then y'all did overhead. The only one I do a little different is I'll do overhead, but I'll do it kind of a moving assessment. So I'll have them start straight over, squeeze. And as they're squeezing, they're slowly lowering their arm back down towards their side. And from that whole time, I'm trying to gauge just that pressure gauge and just see, is there a huge drop at a certain range? Is there pain associated at this drop? And just kind of get a sense from a moving standpoint if there's any problems there.
Yeah, that's awesome. I really like that. A couple questions about range of motion. I know GERD has been something that's been a huge topic in baseball players in the past. How are you, or like, what are your thoughts on the total range of motion and the so-called GERD. Like, what are your thoughts on that?
Yeah, so GERD, I think you just Google anything baseball pitching and try to just get some range of motion, GERD is going to be the first topic that pops up. And GERD is just talking about this gross internal rotation deficit that's going on in the shoulder. And, for me, I think it's real. I think it's a thing. The way I judge it is you got to compare side to side. So everything's a left and right side. There's no like standard, like you're 15 years old, you have to be at this range of motion. Everything's compared to the other side. And then what we know from a baseball standpoint is if you're right-handed and you play for a while, your external rotation is going to be greater than on your left side. And so you go into that knowing that full and well. If it's not, that's a red flag to start with. On the flip side, internal rotation is going to be less on the throwing side than the non-throwing side. So what you do is what I do is I just combine both numbers, and that will give me what is called the total range of motion, total arc of motion, and then I'll compare that side to side. So ER will be greater, but IR is less, and then from there I can compare side to side. And what I'm looking for is it at least equal side to side, but ideally I want throwing side to be greater than the non-throwing side.
Yeah, that's awesome. Because that's super confusing for a lot of younger clinicians that haven't worked with throwers. They don't understand that glenohumeral like retroversion. So that's great to point out. And a couple more things. How do you measure the horizontal adduction, or what are you looking for?
Yeah, so what I'll do is I'll get them into like 90 degrees of flexion. All this is supine. I'll basically grasp at their elbow, just tell them to relax their elbow. It can kind of rest on their side, wherever it is. And then from there, while holding down the scapula, I'll just kind of push it across to the other side, and just going to the point of some type of resistance. And then you can measure it using an inclinometer, a goniometer, just different things. And here's another one that you're just trying to compare side to side and see what you're getting at.
Are you looking at more of like pain provocation with that, or kind of like a traditional crossbody test or AC joint? Or are you looking at true range of motion?
So I'm always looking at pain, if there's pain associated with it. But more than anything, I'm just looking at a true range of motion number. And the reason for looking at it is, in a baseball sense, that motion comes into play during the follow through phase. So after they release the ball, can their body actually rotate across their body as they slow down their arm, or is there some type of pain, lack of motion that is just going to set them up for some potential damage just from the follow through phase?
So, and James, do you have anything to add to that before we move on? Because I have a question in the next topic. Okay. So obviously with any sort of painful activity, right, you want to watch them do it. And I know throwing analysis is a big thing with baseball players or any athlete, overhead athlete. And I want to go back to the IR deficit or GERD. So do you do throwing analyses? And then have you guys come across any numbers that show, how much IR they need to have? And it may be individual, but like how much internal rotation are they actually going into on the follow through phase?
Yeah, so for the throwing analysis question, day one, no, I'm not doing that. Really, I'm not going to even look at that until we get to where they're throwing. By the time they're to me, I'm most likely, depending on what's going on, shutting them down. So I don't really want to throw and watch them throw. I'll do that more as we get closer to return to sport, return to play. And I'm not an expert by any means on throwing mechanics. I kind of have a few things I look at, but I just kind of say, hey, this is what your motion looks like. This is probably what's going on in your shoulder. And try to leave it up to get in touch with their pitching coach if they have one, or they're just baseball coach in general, and be like, hey, can you take a look at their throwing mechanics and see if you see anything? And then in terms of the second question, it's hard to say. So yeah, it is based off different people. So it's more based off body type more than anything. Ideally, I'm wanting them to get, just to throw out maybe a number internal rotation wise, at least 32 to 35 degrees from there. But what I'll look at more is that crossbody motion. So they've got, for me, have at least 10 degrees of crossbody. If you don't have at least 10 degrees, then you're more likely to be set up. So I don't put a lot of stock into the internal rotation purely. I'll look at total arc, but I'll look at their crossbody. Can they at least get 10 degrees? And ideally I want it more, but 10 degrees is my minimum number that I'm going to allow them to do.
Yeah. And then going off that last question, this is from an article, Return to Sport Participation Criteria Following Shoulder Injury, done by Kevin Wilk and George Davies. They give out some general guidelines in terms of shoulder total range of motion within 5 degrees of non-throwing shoulder, exactly what Wesley was saying. And then for people looking for specific numbers, they want a glenohumeral internal rotation deficit of less than 15 degrees. I've seen less than 10 degrees. I've seen less than 25 degrees, but this is just what they cited in the paper. So just a heads up.
Just to have the actual number.
Yeah.
Okay. Yeah. And that's super individual. I mean, I'm more familiar with running and with running analyses, and there's particular angles that the knee's going to go into knee flexion, but it's all over the place. It depends on the person and the body type, like you said.
Yeah. So, and then not to throw a wrench into more plans for people, but it's a little different with left-handed pitchers. So in general, left-handed pitchers, it's going to be more symmetrical side to side. So like their ER is going to be a little bit more symmetrical. Their IR is going to be a little bit more symmetrical. So like I talked about, total arc still applies, but that difference in ER and IR might not be as great with left-handed people just because we live in a right-handed world. And so their chance for that humeral head retroversion is not as great as it if you're a right-handed pitcher.
Oh, that's interesting.
That's awesome. I'm sure there's a lot of rabbit holes with PRI and everything like that. I don't know anything about that. I've heard a lot of people talk about PRI and all of that. So that's a different podcast, but good to
know. that's a probably multi-podcast topic. So Wesley, if you go back to the history and you're asking like how many teams are they playing on? Are they playing multiple sports? From my experience, obviously athletes in general, and when you talk about high school athletes, their parents and friends, coaches, and all that, they can be very I don't want to say hard-headed, but like they're very, I guess I'm gonna say hard-headed as far as letting that they want their athlete son or whatever play, and they don't really want them to rest. How do you go about not necessarily shutting them down, but just starting the conversation of saying, hey, maybe one of the issues is that you're throwing too often?
A lot of it is just being honest with them. It's not trying to sugarcoat anything. It's just being honest with them. I think for parents, obviously they don't want their kid to hurt. So it's just like, hey, he's currently hurting right now. So like, we need to do something about it. And so I'm honest with them, I'm direct with them, but also I lay out a plan from the get-go. I'm like, hey, here's what I want to happen for you to get back into playing. And so a lot of it for me is I actually put it back on the athlete. I'll set guidelines. I'm like, hey, step one is I want ping on and I want that motion to be where I need it to be. Step two, let's get you stronger. 3, do some plyos. And then 4, let's throw. I tell them like, hey, I want you to get back to throwing as quick as possible. But if you don't do what I need you to do, then it's just pushed out longer. So a lot of it is just you put it on the athlete and the parents here, and they understand like, hey, if he doesn't do what he needs to, then it's just going to take longer. And then 2, we try to, I'll try to wiggle with them a little bit. If, they are a great hitter and hitting doesn't bother them, sure, you can hit all you want to hit. You can DH certain situations. I can let you play first base if that's possible. But I mean, I'm going to let them try to play as much as they can, whether it's DH, whether it's being a pinch run or something, so that they still stay engaged in the game. But a lot of it, I just put back onto the kid, the athlete, and just be like, hey, if you don't do your stuff, then we're not playing any sooner than like that.
Would you do anything different, James? Or
no,
similar add-on?
That's spot on. That is definitely spot on.
Yeah, I mean, even in just any athlete in general, like I've had people come in that my goal is to keep them doing whatever they want to do as much as they can without injuring themselves. And that works really well. I've also had a backfire, and they come in and they don't want to play, and I'm trying to keep them playing. They just want to take a rest, and that's great too. So yeah, it's definitely I think it's a tricky conversation, and it's hard because you're going to be communicating with people of all ages, and a younger kids can have a different outlook on their life than an older person. So it's just I don't know. It's always tricky. So if we go into treatment, I know you just kind of said that a brief overview of moving from like general strengthening to plyos to throwing. How are you going to plan your treatment program? Let's say if we have a younger athlete who may be a little bit extra, like a little bit extra mobile or a little bit weak.
Yeah. So kind of when you get to that part, a lot of it is, if they're younger and they're growing, a lot of it is just kind of working coordination. And we've all seen it to where, like, yes, they're coordinated, but then sometimes you question, how are they able to like run without like tripping over their feet, So a lot of it is just trying to work on just full body coordination. I'm working legs, I'm working core, I'm working their shoulder and scapular strength. It's just trying to get them comfortable, get their muscles caught up to this new body size that they have. And then once we get that good foundation, then let's work it into a baseball sense. So, a variety of different baseball strengthening exercises, where there's all that 90-90 exercises, prones, scapular strengthening things, and then progressing to polyos and from there. But then from an older, when I say older, more like people who finished their growth, so they're fully grown and they're not really growing anymore. A lot of times their reason for them hurting is they just don't have the mobility. So whether it's the posterior cuff, their capsule, their lats tend to tighten up on them just from throwing. So for them, it's working on mobility, getting them loosened up, and then working on strengthening within this new motion that they have. So, and it's, James can touch on it too. It's just trying to work on their strength in this new range, but in a controlled manner. So they may still try to compensate because they're just so used to it, but it's actually saying like, hey, let's get through this motion in the controlled sense, and then progress to sport specific plyos and throwing from there.
That's a great breakdown. How do you go about improving posterior shoulder mobility?
For me, first and foremost, it's foam rolling. That's usually the first exercise I give them is foam rolling, targeting their lats, posterior cuff. They can even get a lacrosse ball and roll out on that if they want to. Other things I'm looking to do is a cross body stretch, but modified to the sense where I'm still trying to block scapular motion. So I actually have them go side lying and do it. So they're actually laying on the involved shoulder, pulling across so that we can get some type of pinning of shoulder blade down. And then the last thing is usually some type of lat stretch. For me, in general, the posterior cuff and the lats are usually the tightest of them all, with the third probably being the pec. So if I notice pec super tight, then I'll give them a pec stretch from there. But 9 times out of 10, it's usually the posterior side that's pretty tightened down. So we just have to loosen it up.
Yeah, we know that every time they throw, there's just a huge eccentric load on the posterior cuff. So everything's going to get stiff and tight back there. What are your thoughts on the sleeper stretch? Do you prescribe that at all?
I think I've probably given it to one person one time. And all the times that I've worked with them, I don't put a lot of stock in the sleeper stretch. I don't think it targets what I need it to. And it's just it's like a Hawkins-Kennedy test. So I think more than anything, we're just causing some type of impingement that's uncomfortable. For me, I feel like the cross body stretch does better than the sleeper stretch. But that's just my experience with it.
Yeah, I definitely agree. Instead of cranking on, trying to get more internal rotation, it might be a bony block that they're hitting instead of getting that soft tissue work that you're getting with the foam rolling or the lacrosse ball, tennis ball stuff. So yeah, I definitely agree with that. I use a lot of the same stuff. Do you use any hands-on like manual work or more of the self-education stuff?
I'll do a manual work a lot early on. And I'll use the Graston or instrument assisted I'll just massage it. I'll do some pin and stretch of the lats and posterior cuff and pec. And a lot of times I do that like day one. So we go through everything. I give them these exercises. I give them the stretches, and then I actually like recheck all the motions that we took. And for me, it's just a great buy-in for the athlete, saying, hey, if you do these things, your motion has now improved this much. And then we'll check strength and be like, hey, I haven't given you a single strengthening things. Well, now you're this much stronger. And for a lot of them, they're like, whoa, this actually works. And so it kind of gets them buying in a little bit more. Because like I said, it's all on them. And the more buy-in we can get with them, just the better rehab it's going to go for them.
Yeah, no, I definitely agree. You can make some pretty good changes with some of the soft tissue work in terms of gaining range of motion. And with some of the exercises in terms of like retraining through that new range of motion, I find myself using a lot more isometric like holds and like passive range holds, eccentrics through that new range of motion instead of just going after like the pure strength. Are there anything in particular that you like to do with that?
No, so I'll do a lot of the isometrics, and I'll do a lot of it in the in-range sense. So I'm getting them into this new shoulder flexion motion that they have, and now we're doing some isometric holds. Then I also do a lot of just trying to cue proper muscle activation. So if you're working like a PNF, I'm finding a way to keep their lumbopelvic in neutral, not letting them anterior tilt out of that. Just working pure motion. Same thing with the scap, cue the muscles working so that they can't just keep compensating like they have. So a lot of kind of hands-on just cueing, but also a lot of isometrics is what I'll do for that.
Yeah, these are definitely the athletes that you can't just put in the corner of the room and tell them to do an exercise. You need to be all over them, eyes on a full go, because they'll find a way to do it, even though it's not the right way.
Yeah, you'll be surprised how often you give them this crazy high number of reps, and like 2 seconds later, they're like, all right, I'm done. I'm like, there's just no way in the world you're done.
Yeah.
So are you
Awesome.
working higher? You like to do higher repetition with a lot of this stuff?
Yeah, so I do a lot of high repetitions, mainly because the number of volume of throwing they have to do. So especially if they're pitchers, I mean, if they're throwing 125 times, whether it's including warm-ups and pitch count, I've got to get them strong enough to be able to handle that. So yeah, I'm sometimes giving them 100 plus reps on things. But I'm also trying to just just work on like building strength as well. So I also will drop the reps down, but try to increase the weight as heavy as I can just to kind of build some strength up back there, especially in the rotator cuff muscles. So I'll try to do a little bit of balancing of both ends.
When you get them strong to the point where you're ready to move on to the later stages of rehab, if we talk about plyometrics and eventually a throwing program, how do you introduce plyometrics? I guess you could talk on maybe some lower level to higher level plyometrics, and then we can go on to an interval throwing program.
Yeah, so plyometric wise, I'll start kind of just simple 2 arms, different things, chest passes, overhead passes, just something that's double arm work. Once they feel comfortable, then we're moving into a single arm work. Same thing, kind of like an overhead motion. I'll do some overhead plyometrics, whether they're dribbling a ball off a wall. And then you get into, if you do anything baseball wise, you see people doing all these half kneeling, eccentric catches and reverse throws and ball drops and different things like that. So for me, that's usually one of the later stages of it, but you got to have a good foundation of just double arm with no pain, then single arm, kind of keeping it close to your body. Then we'll get into more of that baseball things that you see people do on a regular basis.
James, what else would you do?
I use a lot of the med ball work too. So I know we were talking about some of the 2-hand and then single arm. I use a lot of the med ball, like med ball slams, scoop tosses, even like med ball sit-up throws, just a lot of different variations there. So that's more of global training instead of just shoulder specific training. So I use the shoulder specific med ball or plyos, and then use a total body med ball plyo just to get the whole body and the kinetic chain linking up together.
Yeah, I think that obviously when you're dealing with a mechanism of injury that requires kind of comprehensive body movement and timed in a particular way, it's important to incorporate the whole body when you're doing your rehab program. And it also, an athlete wants to work hard, so it definitely keeps them involved as opposed to just working on their shoulder. What do you do? I guess before you talk about your interval throwing program, there has been discussion on weighted balls. And I'm kind of too far out of that discussion to really know the state of that. But what are your guys' thoughts on for baseball players using weighted balls?
So for me, I'm not going to say anti-weighted balls, but I strongly discourage weighted ball training. And I've actually had a handful of patients that the reason that they're coming to see me is that they've injured it doing weighted ball programs. So there's a lot of research it's the new fab coming out with weighted balls, and the general gist is you're going to start throwing something that's over the 5-ounce baseball size, and it's going to increase your range of motion, make you stronger, so that when you do throw this regular baseball, you're going to throw it faster. And in some sense, that is true. There is some research out there that is proving that, yeah, you do throw faster, but that's a huge increase of force and torque put on the shoulder and the elbow that it just leads to injuries that come from it. And, there's a systematic review that was out, I think in 2019, that looked at it, and what they came out with is just the study designs aren't great. Everything was kind of very poor, kind of contradicting each other. Training program wasn't great. So for me, I'm not into it, because for a lot of the kids, they're like, oh, I have, we'll say, a month until the season starts. Well, I'm going to start doing this weighted ball program. And they're just going to go out there and throw. They just found this program online. Well, a lot of these programs are designed to be out for like 3 months. These kids are trying to do it in like 3 weeks. So it's just further leading them down into troubles and actually causing them more injuries, because, baseball is just a violent force put on the shoulder and the elbow. So this increase in torque, the body just can't handle it.
Yeah, and Lenny Macrina and Mike Reinhold have put out a couple papers in the past couple of years, and in their research, they showed that there's actually not an increase in shoulder arm speed or strength. It's actually an increase in shoulder external rotation range of motion, and that's their hypothesis and why there's an increase in velocity. But I'm all with Wesley. Like these have to be specialized programs, individualized to the specific athlete. And unless an athlete has like maxed out their linear progression, they're very mature, they're fully grown, and they're hitting it hard in the weight room, and they have the appropriate strength numbers, that's when I'll start thinking about using a weighted ball program, more of that specialty program to add 1 or 2 more miles per hour on their velocity. It's not going to be a great program for developing athletes, because there's so many safer avenues to go through in terms of just strength conditioning that they can do to improve their velocity instead of just adding this extra stress on their shoulder.
Yeah, I mean, it kind of just in I guess the 50,000 foot view with that is, if you're already picking up range of motion just by throwing something hard, put something heavy in their hand, you're going to pick up more motion. I mean, I guess at the layman's term view, it makes sense. If I can throw something heavy fast, and I should be able to throw something lighter even faster. But yeah, there definitely are some negative effects that happen. So yeah, I think I agree with all of that. When you start to get someone into an interval throwing program, or you're ready, okay, we're going to go throw now, what are you looking for them to possess objectively, maybe even subjectively on their end, before you move into throwing?
From a subjective standpoint, I just kind of ask them, like, hey, how would you rate how do you feel right now? Like, do you feel like you're ready to throw? You can ask them like, hey, 0 to 100, how do you feel? And for some of them, you'll be surprised that they're actually pretty in tune with their body and how they feel. So they can actually give you a realistic answer that you could believe. They're not always just going to say, oh, I'm 100% back to normal. Like some of them, like, oh, I feel like I'm 80% there. So that's the subjective thing. It's just having a conversation with them on how they feel. Objectively, it's meeting all the range of motion criteria that we talked about. So flexion being at least symmetrical to the other side, but ideally better. Total arc equal or better, crossbody better. And then from a strength standpoint, I'll do, I want their ER to IR ratio be at least 2/3 strength. And then they have completed the plyo program before I'm looking to start throwing with them. And that's just starting the interval program. There's more I look at when we get to return to play, but that's just what I look for a interval throwing program.
James, would you do anything different, add anything, or is that about what you do also?
Well, I have a couple questions. How do you measure shoulder strength? What are you using?
Handheld dynamometer.
Oh, nice. That's awesome.
So I'll put them in that 90-90, pro 90-90, and try to get them full external rotation, and let's see how you can generate force from there. And then about neutral for their internal rotation.
Okay, great. And then do you use any functional tests like the prone ball drop where they're hanging off the table using like that T motion, or like a 90-90 ball throw against the wall? Do you use anything like that for starting return to throw?
Yeah, so that's usually included in the plyo program. So for me, I kind of lump that into a plyo program. And so, yeah, if they can complete all that, that's just one extra step to get them throwing. I'll sometimes do like an endurance test, like a prone T endurance test, which is just like it sounds. They're doing the T horizontal abduction motion, working on good control, and just trying to compare reps and just see where they stand from that. But I'll look at that more as we're starting to increase our volume and increase our distance of throwing. But to start day one, I don't necessarily always measure that right then and there.
Okay, awesome. And do you do any closed chain tests? Like, I'm not sure if you're familiar with the closed kinetic chain upper extremity stability test. Do you do any of that with your overhead athletes?
For baseball, no, I don't. Mainly just because they don't live in a closed chain world. Everything they do is an open chain. Now, if they had some type of surgical, like a posterior stave, then yeah, I'll probably do that. Maybe not fully test them like the test says, but I'll do that exercise just to make sure from a shoulder standpoint, their shoulder's ready for the force. But majority of the time, no, I don't necessarily do that closed kinetic chain test unless their sport requires them to do it.
Yeah, that's something that we're doing a lot of in Columbia. I'm not sure what was going on. There's a lot of kids that couldn't do push-ups, so their core and their upper body strength was just lacking significantly. So we just added that in with any of our younger, like high school, even some college kids. That was just part of our testing battery. Quick and easy to do, just to make sure that they had that upper extremity strength, stability, and endurance.
What do you, when you get into your interval throwing program, I know there's like, I'm sure your docs have different ones that they like. I know there's a lot online. What do you typically, you don't have to run through each level, but like, where are you starting? And kind of how are you progressing incrementally up to where they're actually full go?
So a lot of it depends on where in the season are we, how long were you actually shut down for, and just different variants like that. So if you were only shut down for a couple weeks, then I might start you out a little bit further. And by a little bit further, I mean like 60 feet, just so I can kind of progress you back. And especially if it's like seasons going on and this is a big season for you, I may try to ramp you up a little bit quicker. If you're a post-op, then I'm taking you slow and steady. We're going to be at 45 feet for a little while. We'll go to 60 feet for a little bit and then continue to progress from there. So it's just kind of depends on what time of the season are we in, how long have you been out, and if there's any other circumstances going on for them. But for me, for a non-pitcher, the quickest I've gotten someone fully back has been about a month. So, I mean, it's still a good while, but it's quicker than if you're a pitcher or you've been out for a long period of time.
What about
Are
you,
you
James?
doing the interval throwing with them? Like, are you throwing with the athletes in the clinic, or are they doing that on their own?
I start with them. So I'll do the first few. So I'll at least do 2 days worth before I actually even give them the sheet of paper. But then from there, I have it structured to where, yeah, every time they come in, we're throwing. But once we get to a certain point from like a facility standpoint, I just can't go out there and throw 120 plus feet with them. So at that point in time, I'm going to turn them loose to practice, and just I trust them to go throw with a buddy from that distance. But I'll do the first few days in the clinic just to make sure we don't have any problems.
Yeah, I agree with that. And that's where that communication with either the coaches, parents, or athletic trainers come in, just to make sure they're doing it properly and they're not doing too much too quick.
Okay, so as far as when you're educating an athlete, let's say they either just got back full go, or I mean, maybe they're just someone who, maybe it's the patient's friend or something's like, hey, my buddy's starting to get a little bit of achiness in the shoulder, whatever, something like that. How are you educating the athletes to either just maintain or sort of prevent their or reduce their likelihood to have injury? So do you have any recommendations for particular exercise or particular places of the body to strengthen or to increase mobility and to prevent someone from getting hurt?
Yeah, so from a skeletonally mature and older kid, I'm telling them, hey, these mobility exercises that we literally do every single day that you come in, you have to maintain that. Just because every research article you look at, every time you throw, you lose range of motion. So for them, it's not necessarily that they got weaker, it's just that they got tighter. And so now their mobility has decreased. So it's just a conversation. These 4 exercises that we've done every single day, you've got to continue to do. And that's usually it for them. It's not so much a strength issue. It's just they got lazy in doing their mobility stuff. Because if you go to any baseball practice, they all have those bands tied up against the fence and they're doing all the different strengthening exercises. Well, their issue isn't strength, it's just mobility. If they're younger, then yeah, I'll give them maybe 3 or 4 strengthening exercises to work on. But a lot of times it's just, you got to maintain your mobility, and you'll be surprised how many times or how often you'll get like a text from one of them, like, hey, my shoulder's acting back up. And you're like, okay, well, have you done any of the stretches that we did? They're like, yeah, I grabbed the bands and did all my strengthening stuff. And you're just like, okay, well, start back on the mobility stuff and I bet you'll feel better. I've had a handful of repeat patients just because they stopped doing the mobility stuff.
So basically the theme is, I mean, it could be one of 2 things, right? So mobility is the most important, but also, especially high school kids, they rather strengthen than stretch. So it could just be like, you have to harp on that just because they're a lot more likely to do the strengthening aspect.
Yeah. And that's just because, this is no knock on any high school baseball coach or anything. They just know that's the warm up that you do. And we've all been there when you're in high school, who actually really stretches. You kind of just show up and play. And when you're 100% back to normal and you're not hurting, then you're like, well, why do I need to continue doing all these things? Like, I'm feeling great. There's no need to continue this. So I think it's just being a high school kid more than anything there.
James, is there anything that you would add as far as maybe areas to focus on? And I'm interested and I don't know if there's any research out there for a particular program to prevent injuries, but is there any areas of the body that you're particularly focused on to help prevent a recurring injury or just prevent one in the first place?
So range of motion is definitely the first thing. And then just making sure that they keep up, like we talked about earlier, their total body strength, because the stronger their legs are and their trunk is, the less stress their shoulder is going to be under when they're playing. So making sure that they're still squatting, lunging, hip hinging, all of that stuff to maintain their strength. And then in terms of injury prevention programs, we all know like the Throwers 10 and the Advanced Throwers 10. There's actually another one that I just saw as I was preparing for this, the Yokohama 9. And we can tie this into the podcast notes, but it's a series of 9 strengthening exercises for like upper body, trunk, and legs, as well as 9 stretches for shoulder, thoracic spine, and hips, because there's a decent research that shows that decreased hip internal rotation can lead to increased shoulder and elbow injuries. So again, making sure that we're thinking about the total body is something that we keep on harping on.
Yeah, a good analogy that I give, I mean, what James says is great is, a lot of times the shoulder and elbow, yes, they're a problem, but they're not necessarily, they're just kind of the things that got called. So for pitchers, everything they do is like a single leg activity. So like if their trunk stability, their hip strength is poor, well, they're probably falling off the mound a little bit. Well, now in order for them to generate any type of force, it's the shoulder and the elbow that's got to kind of catch up to things. So yeah, continuing to do a lot of single leg stuff. And I'll do a ton of single leg squats, single leg like step downs, just different variants from there, just because the stronger your hips are, the stronger your core is, the less stress put on your shoulder and elbow to help kind of decrease the chance of getting hurt. And it's not going to prevent it, but just decrease your chance of it happening.
Yeah. And in that return to sport paper that I was mentioning earlier, one of their criteria to start throwing was to be able to do 8 single leg heel taps or squats off an 8-inch box, being able to do so many reps in 30 seconds with good control. So they're looking at good trunk and lower extremity strength. I know a lot of the kids that I was working with, they were chasing certain numbers with their trap bar deadlift or their reverse lunge in the weight room. So I know Eric Cressy says mass equals gas. So they're they're getting harped on in their schools and their weight rooms with that. So just making sure they keep up with it.
Yeah, I think that's a trend that's upcoming with a lot of younger athletes, is just making sure that they're maintaining that, whether it's multi-sport and just maintaining strength and mobility just for kind of longevity purposes. Is there anything else you guys would like to add about this topic? And we have a few more questions as far as just some simple career advice and how you guys stay up to date on the literature. Is there anything else that we didn't cover? Take that as a no. Okay, well, Wesley, what are you looking into these days as far as, I mean, you can talk about people you rely on for either mentorship or literature on the throwing athlete, but then also just in general in the PT world.
Yeah, so from a overhead, and we'll say baseball perspective, I'm kind of a part of this group within ATI that once every 2 weeks we'll just read an article and discuss it. So it's one good way for me to stay up to date on some of the research that's coming out. Mentor wise that I have, so like you said at the beginning, ATI is just big for just overhead athletes, and we have 2 researchers who are like world-renowned therapists. You can even like just Google scholars, search them, Ellen Shanley and Chuck Thigpen, and they'll have tons of articles pop up. So I have, I'm fortunate to have them at my disposal that I can always ask them questions. A couple upper extremity athlete specialists who are in Greenville that I can call. But for everybody else, you can always look at Mike Reinhold, Lenny McCrena's, Eric Cressy's stuff. They have a lot of good things about baseball wise. And then just making sure as you read that it just makes sense. They're not trying to say anything in the literature that may contradict other things. You just have to kind of, as you read, you just have to analyze the research and does this apply to you or not? Because you'll read one article that says this thing, and then the next article that comes out is going to contradict whatever they just said. So it's just trying to take what you read and to see if it's applicable to you.
Yeah, trying to navigate the dark waters of the research. You can find an article to support whatever you want or to knock whatever you want. James, would you add anything else as far as resources for the overhead athlete?
So you hit the nail on the head with those 3 names. Kevin Wilk is someone that I also follow. He's part of like Lenny McCrena and Mike Reinhold. He was their mentor pretty much. So anything that all those guys put out, and I'm not sure if you guys have delved into this at all, but On Base U, it's kind of through TPI and Greg Rose. They just put out some hitting and pitching screens and evaluations. I'm gone through their TPI certification. I have not gone through their On Base U. So I know that's something that's becoming more popular throughout the baseball realm. I'm not sure if you've gone through that at all, Wesley, or what your thoughts are.
No, I haven't gone through that. I haven't really looked a ton into that to really have an input either way, but no, I haven't gone through it.
Yeah, I've just seen that popping up. May or may not do that in the future. Not sure, but staying up with the research is definitely the way to go right now.
All right, Wesley, last question before we let you go. Any, in kind of like we talked about in our residency podcast, any like career advice or things that you've picked up in our first coming up on 4 years of being PTs that you'd like to share?
Yeah, I think coming out of PT school, I think the biggest advice is, everyone's trying to chase the money aspect of things. Like, I got to make some money to pay off student loans. For me, I would say pick a place that you can actually get mentored in, somewhere that has a good mentorship or has good clinicians that you can mentor off of, because that's just going to set you apart. Sometimes if you're chasing the money, well, you're getting into the situation where you're not going to be able to learn, and it can lead to some burnout. But if you have people that you can get mentored by or ask questions with, it just sets you up to be better. And it kind of, the residency, some people say, puts you like 3 or 4 years ahead of your peers who didn't do the residency. So I think the biggest thing is just finding a place that you can continue to learn, continue to ask questions, because we all know you come out of PT school, you know some things, but there's a lot of things you don't know.
Oh yeah, like 5% of, if that, what's out there. I think you have a unique perspective because you did a year in practice and then you went to the residency, whereas me and James went straight in. So yeah, and that chasing the money thing's important because obviously that's a reality. But that's, you got to do what you got to do there. But I think it's also really important to like what, to feel confident in what you do, because then I feel like you'll like it. And that's, to me, just as, if not more important.
Yeah. And for me, I think taking that year off in between, we'll call it the gap year, whatever we want to call it. I mean, it was great for me because I learned how to treat patients without having like a CI right there. So like I was fully on my own. So I kind of had like a general, we'll say, baseline of how to do some things. And then it led me get into the residency and saying, okay, I kind of know what to do with these things. So let's try to fine tune and find the best thing, as opposed to being fresh out of school and not really having anything like experience to back it up on what you're doing. So I think you go either way if you want to do residency, and you'll be in great shape.
Yeah, I think with that, you were able to ask the right questions. So with me, I was just soaking it all in from a fire hose. I didn't know what was going on, but you had that experience and you were able to understand, okay, what am I doing right? What do I need help with? And you can get that specific help, which is a great way to go.
Yep. No, I think we all are pretty happy with our decisions thus far anyway. All right. Is that everything? Are we good?
That's good. We can wrap that up.
All right. Yeah. Well, Wesley, thanks for jumping on. You're our first official guest. So, I mean, that's a pretty big deal. We appreciate all the back and forth and all your knowledge on this topic. And hopefully maybe we get a little bit deeper into some of these topics and we'll get you back on.
Yeah. I appreciate y'all having me. Great honor to be the first guest on this podcast. So thank you.
Yeah. All right. Y'all have a good one.
All right. Take it easy.
See you guys.
Thanks for listening to the Athletes Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website.